pleasure to be here. I think the science of resuscitation and fluid resuscitation has come a long way in the last several years, and just to kind of reset where we are, Dr. Wong talked about pediatrics and kind of the theory behind hyperchloremia. Then we had a lecture about more of the basic mechanisms and do we really understand what high chloride is doing in resuscitation. And then my 10 minutes here is going to be more on the clinical effects and what we know about the clinical effects of saline and hyperchloremia. And then I think our host is going to sum it up at the end. So thank you for your attention. I'm Wesley Self. I'm from Vanderbilt University in the US. I have no specific disclosures for this talk other than I probably have an intellectual conflict now with balanced crystalloids. I speak and write on balanced crystalloids quite a bit. So take what I say with that disclosure that I'm invested now in this topic. Here's my research funding that does not have direct relevance here. So the question, kind of the basic question, what is the best IV fluid? And I think has been hinted to here, we're not going to have one answer to this. The best IV fluid is probably going to be dependent on the patient with things like the acute condition, the electrolyte levels in your patient, the comorbidities your patient may have. So I'm going to reframe the question slightly. I work clinically, mostly in emergency departments, and what we're faced with often there is the acutely ill patient that we believe needs volume expansion. We don't have a lot of information on our patients yet, particularly from laboratory work. And the question there is, if you're grabbing a solution off the shelf, which one should you grab first? So in the most patients on a population level, which fluid would you start and have the most benefit? So I'm reframing the question slightly. Think of this as the context of you have a new patient that you think needs resuscitation, which fluid should I start with? So as everyone here knows, resuscitation fluids can be broken down in these categories. I'm not really going to talk about colloids much. There is some controversy about colloids. Most of the recent literature, though, has been on crystalloids, so we'll focus over here on the crystalloid arm, which of course are these fluids with small molecules that don't exert oncotic pressure. So as was mentioned earlier, crystalloids can basically be broken down into two big groups, these balanced solutions, which we'll talk about and define a bit more later, versus saline or 0.9% sodium chloride, or normal saline or saline, all the same thing, right? So 0.9% normal saline. The balanced crystalloids can be broken down into basically two categories: lactated ringers, or these newer solutions, plasma-like normosol. So here are the basic crystalloids available to us today in most of our hospitals. So, sorry about that. Where do you go back? So the first column there is human plasma, the basic chemistry panel we get on our Chem 7s. And then you have saline, which you immediately note has higher than physiologic levels of sodium and chloride. And then your lactated ringers, or ringers lactate, which our group considers a balanced solution. There's some controversy about that. It may be between a balanced solution and saline. And then your classic balanced solution, or plasma-like A, all the way over on the right side. So what you immediately notice is the differences in chloride levels, in which the previous two speakers spoke at length of why that may be important. So saline has a supraphysiologic chloride, whereas lactated ringers and plasma-like A have more physiologic concentrations of chloride. And we think, we don't know actually, but we think that might be the driver of any clinical differences we may see when using these different solutions. So there's concerns with all of these crystalloids, actually. The saline, you get more concerns about hyperchloremia, metabolic acidosis, and perhaps decrease in renal perfusion, as was gone over earlier. But balanced solutions have potential concerns as well, including alkalosis, the low osmolality, which can become particularly important in brain-injured patients, and hyperkalemia. So we don't know exactly which solution is best for all patients. As was alluded to earlier, we've done some preliminary work in this area. This was our group at Vanderbilt, did the paired studies, which were introduced nicely in the last talk, published last year. And what we did is we took a large group of patients, about 30,000 patients over a 2-year period, and looked at two subpopulations. One on the left, which were the non-critically ill patients. So these were patients resuscitated with fluids in our emergency departments and then admitted to the hospital wards. And then the other population were the critically ill patients treated in our intensive care units. So we were looking at the same question in two basic populations. And that question was, which is a more effective resuscitation fluid? Is it the balanced crystalloids And we used a combination, which could be a criticism of the studies, we used a combination of lactated bringers and plasmolite, so clinician choice, versus saline. And we did this in a single center, pragmatic, multiple crossover trial. As I mentioned, the SALTED study, so the first study was basically non-critically ill floor patients. And the second study, the SMART study, was the critically ill patients treated in an intensive care unit. So how did we do this? These are incredibly difficult studies to do, actually, because fluids are one of those resuscitation tools that patients get immediately, right? And trying to identify and randomize patients in the midst of an acute resuscitation is extremely difficult. So we decided to go with the cluster approach to these studies, and I'll explain that here. So here's the typical flow of patients in hospitals. Patients come into the emergency department, and they go to a discharge, which we did not study, or they go to a hospital floor or an ICU. And then, of course, ICUs have patients coming from the emergency department, the operating room, and other locations like the floor. So what we did is we took our floor patients, this group, and analyzed it in the SALTED trial, and we took all the patients in the ICU and analyzed it in the SMART trial. Here are the fluids that we controlled in these studies. So over about a 2-year period, which studies were on protocol. So the fluids that we controlled were in the emergency department, the operating room, and the intensive care units. How did we do that? So we used this crossover design based on monthly crossovers. So if you start up here in the emergency department in January 2016, basically all patients who came into our emergency department that were getting resuscitation fluids received a balanced solution. That's the B. Remember, that is clinician's choice between lactated bringers and plasmolite. In our setting, that was largely lactated bringers. And then at the first of the month, every month, we crossed over for the next 2 years. We did this in all of the operating rooms and all of the intensive care units. The intensive care units were on the same schedule with the emergency department if they tended to admit patients from the emergency department, such as the medical ICU. Surgical units were on the same schedule as the operating room, such as the surgical ICU. Outcomes, as was mentioned earlier. The primary outcome in our ICU study was this MAKE-30, so major adverse kidney events, which is a composite. It is a composite of new renal replacement therapy, a doubling of creatinine from baseline, and death. In the emergency department non-critically ill study, our primary outcome was hospital-free days. This was probably a mistake on my part. I did not think a priori that the non-critically ill patients, we would necessarily see a difference in the MAKE-30 outcome, so we used this hospital-free day. You'll see at the end that was probably a mistake on my part. So, slide shown earlier. So what did we see? In terms of electrolyte concentrations, what you see here, patients starting in the emergency department at time 0 started at the same chloride level on the y-axis, and they separated. Patients treated with saline had higher chloride levels, and that higher chloride level persisted for days, up to 3 days. In the ICU, if you take time 0's ICU admission, patients who were treated with saline started at a higher chloride level because remember, they were being treated in the emergency department and operating room based on the crystalloid choice of the month. And when treated with saline versus balanced crystalloids, what you see here is that patients had persistent differences in chlorides out to 7 days. Here's the hospital-free day outcome in our non-critically ill SALTED. What you see is totally null. So this was a null on the primary outcome trial in which hospital-free days, which is a composite of length of stay and death, were not different between saline and balanced crystalloids. And here's probably the most interesting outcome, and we can speak on this as long as anybody would like. So in the non-critically ill emergency department patients, remember, treated with saline or a balanced solution, largely lactated bringers, in about 13,000 patients, we saw a difference in the MAKE-30 outcome. So those treated with balanced crystalloids had a 4.7% incidence of this MAKE-30 composite renal plus death outcome, compared to 5.6 with saline, and in this very large sample size, that is statistically different. In the critically ill ICU patients, similarly, we saw about a 1% absolute difference in this MAKE-30 outcome, 14.3% in the balanced group versus 15.4% in the saline. This is consistent, I think, with the literature. So these are the ANZIC studies, largely that was mentioned in the last presentation. So these are the UNOS studies and the SPLIT trial you'll see intermixed here with the SALTED and the SMART trials, which I just presented. And what you see is here on the x-axis, over here which favors saline on all of these outcomes. You really don't see on large population-based trials anything favors saline. You have some null results, such as the AKI and split, like we talked about, such as the hospital-free days and the SALTED trial, like we talked about. But in general, most of these outcomes are favoring the balanced crystalloids. So in the last couple months, we've started to look at specific subgroups within these trials, and we started with sepsis. And we started with sepsis for a couple of reasons. One is that patients with sepsis tend to get a large amount of fluid. Secondly, they are particularly vulnerable to outcomes such as death, acute renal injury, and persistent renal failure. So looking specifically now at the septic patients in these trials, there are about 1,600 patients, which represented 10% of the cohort. We collected our sepsis patients initially based on ICD-10 and did reviews of all the charts, and 70% of these patients had a primary reason for ICU admission of sepsis. So it was a sick population. 34% at baseline at the time of ICU admission were on vasopressors, 40% on mechanical ventilation. And they received a lot of fluid. So the mean fluid volume here was about 6 liters over their hospitalization. And these are new data. This is what we've found. So this is an absolute mortality difference in the septic shock subgroup of our SMART trial, showing about a 5% absolute difference in 30-day inpatient mortality favoring balanced crystalloids. And you can see the other outcomes here generally in the same direction. Interestingly, so there's the subpopulation again. What happened to other outcomes we care about, such as resolution of shock or the administration of vasopressors, and what you see on the graph here on the left. So this is norepinephrine equivalent dosing. So this is our vasopressor dosing, and what you see immediately is the balanced crystalloids tended to get less vasopressors over time, suggesting an increased time to resolution of shock, so a shorter time to resolution of shock. And our lactate levels, despite lactated ringers having some lactate in it, lactate levels tended to drop faster, also in the balanced crystalloid group compared to saline. So additional work ongoing now in our group and many others around the world, looking at specific types of patients, such as we mentioned DKA, trauma, sickle cell anemia. We need to look at specific types of patients now and understand the differences of saline and balanced crystalloids. There's also this question of lactated ringers versus plasma-like, two types of balanced crystalloids. We've undertaken a trial that's looking at that now, which is called the BASE trial. So getting back to our original question, which fluid would I grab off the shelf if I had a sick, undifferentiated adult who I believe needed resuscitation? In our trials, actually, we largely used lactated ringers. That was based partly on the cost. The cost of lactated ringers was lower than plasma-light at the time of our trial. We've learned a lot about lactated ringers now that we've started to give it to many, many patients. It has the calcium in it, and there's some theoretical problems with the calcium in theory, and in all of the nursing manuals, you'll notice that they say lactated ringers should not be concurrently given with PAC cells because of the risk of microthrombi. And the calcium can theoretically make compatibility with different medications such as ceftriaxone difficult. So there is a slightly lower than physiologic sodium concentration of 130 for lactated ringers, which could potentially exacerbate hyponatremia. And we talked about the low osmolality. So for me, right now, based on the evidence that we have, if I have to grab a solution to resuscitate my patient, I don't know much about that patient yet. I don't have their electrolytes. I'm going to grab a balanced crystalloid, and that would be plasma-like or normal cell for me now. Thank you, and I think we can open for questions.